are to regain previous ability to perform activities of daily living, and we try to maximise the potential of movement to achieve the best possible outcomes for our patients. And it's very centred around patient goals. So, what is physiotherapy? Well, physiotherapy is a health-based science profession, and we believe that movement, exercise, all will sort of speed up the healing process and will all sort of facilitate getting someone back to what they want to do. And that's really like the core aims of our profession and what we try and achieve as physios. And that can involve education, it can involve health promotion, it can involve sort of treatment techniques, hands-on techniques, it can involve giving exercises, helping someone do exercises, the use of heat, the use of ice. It really covers a lot of core essentials, but the main thing that physio tries to achieve is getting that person back to doing what they want to do, really. And so here, I've just got a few pictures just showing, you know, physios working in different settings and physios doing some hands-on techniques or showing exercises or doing exercises to help whoever they're helping. Okay, so this here is basically a problem list which most people tend to have after they've had surgery of some sort. It could be surgery on the hip, knee, ankle, wrist, whatever really. And generally this is the list of problems that people have and what our aims are with post-op rehab. Generally, one of our aims is to reduce pain with the person. They've just had an operation, someone's gone in there, they've moved muscles around, they've attached different things, there's a new implant in there maybe, they've moved, you know, they've cut something, so people are in pain. And in the UK, physios are quite often one of the first points of call to go and visit one of the patients, and so we can identify if someone's in too much pain, for example, and we flag that up with the medics, we flag it up with the nurse and say, hey, this person's in too much pain, they need some analgesia, and what we aim to do is give them some analgesia so that they can do some physiotherapy. So we time it, we try and time it so that half an hour they've had some pain relief and then we go and see them so that this is all in their blood and that they can move the affected limb. And we also believe that moving limbs and exercising is one way that people, it's one way that we reduce pain. So you've got this whole flushing effect, new blood coming to the joint, movement, serotonin, all this can help reduce a person's pain levels. We aim to reduce swelling. Surgery can cause swelling in most patients. One of the things we do is we can teach them some things to help minimise swelling. And that's really important on day one, which I'll talk on about in a second. We aim to increase range of movement of the affected limb, so generally it's been operated on. People are anxious, they don't want to move it hurts to move, they don't know how to move it, they think it might break if they move it. So we just aim to try and encourage people to move the affected limb, and if need be, we'll help them to move it, we'll show them ways that they can move it, we'll support them to move it, with the primarily aim to increase that range of movement that they've got. And then following on from that, we hope that by moving the limb, they're going to start to regain muscle strength again. Surgery, just by cutting muscles, by moving muscles, prior to the surgery, things will have weakened because they haven't used them. All these things will sort of cause muscles to weaken. And so what we try and do, get them moving, start giving them exercises, and that way this muscle, whatever's been affected, can start to strengthen straight away. And that's one of the best things really, to get things moving so that the strength gains happen straight away, straight after surgery, because that's the best thing for your patients. Generally after an operation, something called proprioception can be altered, and that's your sort of awareness of the joint in space. And so there'll be a limited feedback from the joint back to the brain. So hopefully by moving the joint, by getting up and walking, it just helps to start that proprioception phase up and running again. And one of the best things we can do is mobilise a patient. Get them up, sit them on the edge of the bed, get them standing, get them walking. And that incorporates everything. It gets range of movement going, it reduces swelling, it gets muscle strength going, it gets them walking, it gets them functional again. And that's one of our primary aims really. Another thing that physiotherapy will do is people are anxious, so we'll educate the patient, we'll tell them what they can and what they can't do, and we'll extend that advice to family members, to carers, to whoever needs to know really. So all of this is really just trying to facilitate that normal recovery process so they can get back to whatever they were doing as quick as possible. And one of the other things we will do is consider the patient's chest, but I'll talk about that in a second. I just put this slide in because rehab always has to be really goal-focused. You have to have an aim at the end of the day what you're trying to achieve. So probably the surgeon will have fixed a joint, whatever joint it may be, for the reason to reduce pain and to get them doing things again. But patients really need goals. They need to think, right, actually today I am going to get up, I'm going to sit in the chair, and then I'm going to go back to bed, and that can be a goal. Or once they've achieved that, things need to progress. They need to be like, right, I'm going to get to the toilet today, or right, tomorrow I'm going to walk outside. Tomorrow I'm going to get to the post office. You know, little goals like this, you need to be setting with your patients so that they keep motivated and so that they have an aim and they know why they're doing all these things. I'm sure you know that all goals should be specific, measurable, timely, achievable, realistic. So just set realistic goals that people can achieve, but just keep setting them. So you've got short-term goals, and then they all tie in to fit in with a long-term goal, which might be to return to sports, or it might be to get back to work, or it might just be to walk to the park without having that pain that they initially did. So one thing we do in the UK is we sit down and we say to the patient, right, what do you want to achieve? And we write goals together, patient and physio, so that everyone knows what we're working towards. And we have that all written down so that people forget. You can remind them, hey, actually last week you couldn't do this, but now you're achieving that. Or, you know, this is what we're trying to achieve, so you need to keep working. And so they're a really good motivational factor, which we use, and hopefully maybe you could use too. Okay, so this patient, whoever it may be, has just come out of theatre, they've just had an operation, and so they will be affected by the effects of the anaesthetic. Just basically, the anaesthetic will slow down their breathing rate. They'll be lying on a table for a while, they'll have been flat, they won't have been taking deep breaths, so they'll have this decreased expansion of the lungs. You'll often find because they've been lying down, they retain sputum, they retain mucus here, and that can be a complication. It can cause pneumonia, and it can cause, can't say it, and you know, maybe they've been lying down for a long time, there are risks of clots and things like that. So something that you all need to be aware of. But physio can help sort of reverse some of the effects of the anaesthetic. But just keep these key points in mind. So what we do in the UK on day one is we just talk to the patients about, hey, you've had an anaesthetic, this is what you need to do. So we remind them, really basically, that they need to take deep breaths. And that just gets those lungs opening up again. It gets this really nice big expansion. We just teach them really simple breathing exercises. So 5 deep breaths an hour, so they're breathing right to the base of their lungs. We get them coughing. We get them to do a thing called a huff, which is a like that. And what that does is it forces the air out of the lungs, so it gets this it gets the airways working again, basically. And if they did have the sort of sputum trapped there, it would get them up. It would bring the sputum up, which is brilliant because we don't want that lying there because that can cause a risk of a chest infection. One of the best things we can do for somebody's chest is to sit them upright. So especially if they've just had an anaesthetic, it's day one, sit them upright. Straight away you've got that lovely lung expansion, and it just helps get everything moving straight away. If they're doing really well, they can mobilise, and I will go on to that. So what we do in the UK prior to getting someone up and prior to seeing them on day one is we just have a look at the surgeon's notes, and everyone in the UK writes post-op notes, and we know exactly what they've had done. So the surgeon will include any instructions for the physio that we need to know in those notes. So we always check those notes. And it's very helpful to know if in theatre they had any blood loss, if their HB level is low, or if they needed a transfusion. Purely because that is something that can affect their rehab. It can make them slightly slower initially. It doesn't halter it, doesn't stop it, but it just means we need to take it into account. We'll get some post-op instructions from the surgeon, so he might say, the operation went well, but I don't want them to walk on it, so they're going to be non-weight bearing. Or maybe some patients might be partial weight bearing. And that just means that we need to take some special consideration. It might mean that people can't put weight fully through the leg, and we can teach them how to do that. And how to sort of manage long-term until that sort of status has been removed. We just like to know what will be attached to the patient. So are they in a plaster? Are they in a sling? Have they still got the epidural running? In the UK, we have these things called patient-controlled analgesias, and they can be attached to the patient. So it's nice to know what's attached to the patient so that we can have extra hands and extra people with us so that when we get them up, they can hold all the attachments and we can focus on the patient. So that's really key to know. And it's very important to know whether they've had an epidural. Day one, you can get them up, even if they have had an epidural. However, it's really important to know that they have got feeling back in their legs, and they can lift their legs up and down. So we'll just ask them in the bed, can you lift your leg up and down? Can you feel my hands? And if they can, we know that the effects of the epidural is running out. If they can't feel their legs, it means that if you do stand them up, obviously they're just going to go down straight away. So something to bear in mind. We make sure they've had analgesia before we go and see them, because it's cruel not to do that. And we just make sure that all their observations that you take in the hospital are within that normal level, so that they're not running a high temperature, their blood pressure's not too low. We want to know that they are oxygenating okay, and that their infective markers are in normal regions. Purely because if you get someone up and their blood pressure's really low, there is a chance that they might faint, or if their temperature's really high, there might be an infection somewhere. And so which you need to take into consideration before you do mobilise someone. If there were precautions written in the post-op instructions, typically for total hip replacements, total knee replacements, there are some things that you can and can't do. With the hip replacements, there's a chance, if the hip is put in extreme positions, that it could dislocate. So they don't like, well, surgeons don't like the hip bending more than at 90 degrees, which would be that angle there. And so equally, if you went to the floor, that creates that same 90-degree angle. So no going to the floor, no bending the hip more than 90 degrees, no crossing your legs, and no twisting, because all of that might put the hip at risk of dislocating. With the total knees, it's slightly easier. They just don't want you to kneel on the knee and put too much weight through the new prosthesis. And it's really important that all of your patients don't do these activities for 3 months. The theory is that after these 3 months, your muscles surrounding the joint will be stronger, and so you can do these positions, but not up until 3 months. Okay, so day one post-surgery, when we go and see our patients, they've had analgesia, they know we're coming, and what we do is we teach them our deep breathing exercises, and we encourage them to maintain their circulation. So we teach them some really simple ankle exercises, so get your ankles moving up and down, and sort of side to side, just to eliminate the risk of DVTs, and to start that movement process going. And in the next couple of slides, we've got some really simple bed exercises that you as doctors, physios, nurses can all teach your patients, things that they can do whilst they're in the bed. So just because they're lying there after the operation doesn't mean that they're getting a rest. They can start exercising straight away. And so the first one that patients can do is to start squeezing their buttocks together, holding it for 5 seconds, and then relaxing. Really simple, everyone can do that. Squeeze your buttocks, hold, 5 seconds, and then relax. And we get people to do that 10 times in a row, 3 times a day. These are all on some sheets which we can give you later. So that's the first one. Second exercise is with the quadriceps. So say if the leg was out straight on the bed, what you do is you would get them to push their knee straight into the bed, and that forces the quadriceps to contract and gets the quadriceps to start to flicker and start to move. So you would push down into the bed for 5 seconds, hold it, and then you'd relax. And again, you'd do that 10 times, 3 times a day. You'll see there's a pattern to this. Next one is just getting them to move the knee. Could be they've had a hip operation, could be they've had an ankle operation, or even the knee. Can't do any harm by just getting that knee to move. So slide it up and down. If they're finding it a bit tricky, you can put something slippery under their heels so that they can, because sometimes things get caught on bedclothes, but just get the knee to go up and down in the bed. This one targets the inner muscles of the quadriceps. So if you can roll up some towels, 2 thick towels or a towel or anything to create a nice roll, you would put it under the knee, and then you same again, you push the knee into the towel, and then lift the leg. We can practice this later if you want. A really nice one because it gets the inner muscles of the quads firing again, which is really needed if they've had a hip or a knee operation. And then, so the fifth bed exercise we get people to do are to lift, keeping the leg nice and straight, to lift their leg off the bed. And we would just get them to just take that much off the sheets, hold it 10 seconds, and then slowly lower. Again, 10 times, 3 times a day. So what we do on day 1 is we teach them those 5 exercises. They get a handout with a sheet so they can read it at their leisure, and then we tell them it's their responsibility to do those exercises as we've just suggested. So we show them how to do them, and then they keep doing those exercises. If all things well, their obs are fine, the operation went well, there's no reason, medical reason why they can't get up and the surgeon's happy, we get them out of bed. And they can do that day 1, no problems. And it's best to get them out of bed day 1 because it gets everything moving much quicker. It gets muscles stronger quicker, it gets the person feels a bit happier. It just speeds up the healing process basically. So we will help them. We're not saying how much better you get, but we will help them to do it. So we get someone extra to hold all the drains, the drips, anything like that. And we hold the affected limb, we help them move it to the edge of the bed, and then we just sit them on the edge. We give them a bit of time to adjust because their BP might have dropped, they're feeling a bit anxious, they're breathing deeply. Let them acclimatise to just coming up to sitting on the edge of the bed. If they're managing on the edge of the bed, no problems, we stand them up. Once they're standing, we generally put a Zimmer frame in front of them, they can lean on that, we can tie all the drips and the drains to the Zimmer frame, and then it's brilliant, because you've got them up, you've got them weight bearing, and they're standing. There's weight bearing exercises is really good for muscles, so. And we just monitor them. If they're doing fine in standing, no problems, they take a couple of steps and they sit in the chair, and generally in the UK we get them up for lunch, so they have their lunch in the chair and then they go back to the bed for the afternoon. And people feel much happier. Once they've done that initial movement, the next couple of days they're much keener to move because they know it's not a problem to move. Over the next course of the couple of days after surgery, things get a lot easier. Drains get removed, dressings get taken down, and so movement can happen even more so really. We get people moving to and from the toilet with Zimmer frames, with support, someone will go with them. But we just help them to walk sort of around the wards so that they can start exercising, standing up and weight bearing really. We're always quite sensible because days 2 and 3 they still are suffering from an anaesthetic. So we do have chairs close by and we ask them how they're doing. So say someone comes over slightly dizzy, slightly hot, we can just say, hey, sit down. They take a couple of minutes and generally they're fine. So it is advisable to have someone there whilst they do it so you can minimise these risks. But you just have to think really, just be a bit sensible as you do mobilise them. And then as things get stronger, they're moving around, their confidence increases, the range of movement increases, we sort of start this progression. So initially they're on a Zimmer frame, then we start to progress them onto crutches. If they're managing the crutches, they go to a stick, and eventually, hopefully, they might get to be independent. It does depend on their age and what they were doing beforehand, but that sort of doesn't matter really. In hospitals, the patients should be doing their exercises 2 to 3 times a day. And the patients know that they've been given the exercises, it's their responsibility to do them independently. And we just remind them. Other things you can get them to do, once someone's walking around, once the drips have been removed, they're managing well with the bed exercises, get them doing some exercises in standing. So we use sort of work surfaces, anything that they can lean on, get them to move the hip up and down, out to the side, behind, things like that, because these are additional exercises against gravity, which are a bit harder, so we'll continue the muscle to strengthen. It continues these strength gains that they get. Get them marching on the spot if space is a bit limited. Get them doing squats, which is when you bend both knees. Like I was saying earlier, proprioception can be off and patients' balance can be off after surgery. So just start to work their balance. So get them doing heel raises, toe raises, side stepping, And all these things just help to speed up that recovery process and get these muscles a bit stronger. Might not be a problem in Ghana, but if someone asks you, they're on crutches and they're not quite sure how they're going to get up and down some steps, this is how you teach them. They go up the steps with their crutches, but they take the good leg, so that's the non-operated leg, up the stairs, and then coming down, they take the operated leg. So it's good leg up, bad leg down. And then mobility progression in the hospitals in the UK is we just advise them to take an aid with them until these strength gains have happened and they feel confident to walk unaided and they don't have a limp and their balance is back. So, and we just get them to build up their mobility step by step by step. So initially, they might just be walking for 5 minutes a day, but like we said, we set goals, so we try and make them walk for 7 minutes a day, 10 minutes a day, 20 minutes a day, and you just keep progressing them so that they're getting better and better, week by week, day by day, and things like that. And then once they are recovered, so sort of 3 months after the surgery, 6 months after the surgery, it's important that people keep staying active and they keep, they don't necessarily have to do the exercises, but they do take up an activity which maintains muscle strength and maintains movement. This slide was just some things that generally people always ask me, and this is just the advice that we always give them. People always say, oh, it hurts to move, so I don't want to. And we always advise that moving shouldn't be agony, but there might be some discomfort, so have some pain relief and then try moving. Don't do anything that causes you lots and lots of pain, but you might find that walking on it does hurt slightly. Generally, the more you do it, the pain goes less and less over the next couple of days. We've talked about goals, like I just said in the past, get them moving, get them doing something new each day. It is not advisable if someone is in a lot of pain to say, okay, rest up, stay in bed for this couple of days. It's not going to help. Everything's going to weaken, they're going to be immobile, muscle contractions could happen, muscles will weaken. It's wrong advice basically. So just get people doing what they can do. That's the main thing. People always ask about sleep. Generally we say sleep in the position that's comfortable. After hip surgery, it's not advisable to sleep on your side. They do need to sleep on their back for the first 3 months, but generally we try and get them as comfortable as possible. This bit was just to say that full recovery can take many months. It's not going to happen overnight. If there was lots and lots of pain, lots of weakness prior to the operation, it is going to take time for these muscles to strengthen, for your walking pattern to become back again. And so full recovery may take a year, but it's important that you keep up with your rehab, you keep doing exercises and you keep moving. We just put this slide in for the nurses and for the doctors and for the people that are dealing with people post-surgery. They're often quite immobile initially, but especially when they come out of theatre, and it's essential to the staff that you look after your back. So make sure you are lifting patients correctly, bending your knees, setting your tummy muscles before you move something. It's best to use equipment instead of you pulling and pushing. So if you can, raise bed heights. I don't know if you have slide sheets, but using something slippery so you can pull the patient towards you. And get some help. If you can't move someone, wait until you have someone else to help, because that will protect your back, so you'll be happier in the long run. And we just wanted this slide in just to say that we are aware that rehab can be delayed slightly by some of the complications of surgery. It doesn't mean that rehab's not going to happen, but we do just need to account for sometimes if the wound is taking a bit of time to heal, there might be additional pain with this, or that they might not be able to go to the full range of movement. So we might have to sort of minimise or alter exercises to allow for this. There could be, someone could just be slow to heal, so the soft tissue might be slow, the bone healing might be slow, and so you just need to take account and just let them be a little bit slower than sort of everyone else really. Worst case scenario is if the implant becomes a bit loose or it becomes infected, and there's nothing that we can do about that, but you just need to be aware of that while we are rehabbing a patient. And I just wanted to remind you that immobility, prior or after surgery, can lead to chest complications, and that can be a complication of surgery. So it's best not to leave people lying there 2-3 days. It's just silly, really. It's just best to allow them to do what they can. So just get them sitting on the edge of the bed, or just get them to take a stand for 5 minutes and then get them to sit back down, and that will help alleviate that complication of pneumonia. And then I'll just leave you with this quote, I think. I'll let you read it. There's a little summary there, but you can read that as well. Okay?
Seeing a few of his pictures, you love it.
Good evening, everybody. Or is it still afternoon? This is a pet subject of mine, foot deformities. And courtesy of Motec, I was requested to show up in Africa and perhaps started to fill in the cracks. I can remember the first time I came to Ghana, then I wasn't too bad. At least I still managed to get some work done. Around the same time that Motec invited me to join them, I had the privilege of going to Nigeria, which is where I'm from. And orthopedic services in sub-Saharan Africa is 50 years behind the rest of the planet. It is that bad, and it is not an exaggeration. And for the first 2 days, particularly after I went to Nigeria, I just sat on my bed and I didn't know where to start. It is that bad. But we can do it. We can do better. And that has been what is motivating me. Because I know there's plenty of good people who want things to be better. And with the support of other people who will help them to get to where they're going, we can do a lot better than we're currently doing. So don't think you can't. You almost certainly can do better. Foot disorders from the cradle to the grave. I'm an orthopedic surgeon in Middlesbrough at the James Cook University Hospital. I do most things, but I was also trained as a pediatric orthopedic surgeon, which is actually where my main interest lies. In my own clinic, perhaps because I have a bias for foot surgery in particular, I would get, apart from the usual hip and knee replacements, ankle replacements, I would get quite a lot of foot problems, particularly in children, and how far you can get. So you can imagine if you do that in your 20s, it limits you greatly, particularly if you haven't finished your education. If you lose your leg when you're really young, 3, 4, 5, 6 years old, which is not uncommon in Africa, and very often for things that people should not be losing their legs for, you can imagine that child has no future. In fact, in some cultures, if a 2 or 3 year old loses his leg, sometimes that child, they will kill that child will be allowed to die. So these are really serious things with serious consequences. Many relates to quality of life. Unaddressed childhood foot pathology can result in long-term significant disability. So no matter how brilliant that child is, because the child is so neglected, and in Africa it's so bad, particularly people with disabilities, most of the schools don't even have steps, they don't have handrails, they don't have this. So that child automatically can't get to so many places that it needs to get to make progress. So you already limit that child's chances in life. So it is important that a lot of these pathologies are addressed early, so the children don't lose their legs. And that goes for adults as well. Childhood foot disorders. These are mainly congenital. You're all familiar with club feet, but there are also other things like flat foot, metatarsus adductus, a skew foot. A skew foot is a Z foot. The foot looks like a Z shape. You will see it sometimes. The trouble is, because you're familiar with club foot, every single foot you see that's not normal, everybody calls it club foot. It isn't club foot. There's plenty of people walking around with legs that are not club feet, and everybody thinks it's club feet. Trouble is, if you don't recognize the difference and you treat it for club foot, well, then they will be footless. Fractures are rare in children, in the foot, in children, but very often they are missed. Infection in children is often missed, because when a child has an infection in the foot, the first sign is they don't want to walk. They want their mother to carry them. You know what it's like in Africa? This child's been walking around for the last year or two. All of a sudden he's putting his hands up, wants his mother to carry him all the time. The first response is for the mother to flog him. You got to let walk. And then if that persists, then, well, the trouble is that will take about 2 months before the mother then clicks and thinks, God, this foot is actually swollen. Unfortunately, this is not a problem that the local herbal man can deal with. It's not trauma, it's an infection. So they go to the medicine man, he rubs leaves on it. By the time he gets to the orthopedic hospital, the whole foot is swollen. There's a big ulcer in the sole of the foot. And the child has lost probably 1 or 2 or 3 of the tarsal bones. We're getting very close to an amputation. All because of a simple puncture wound to the sole of the foot. Somebody didn't pick up. This child's going to lose their leg at age 5. It is serious. Infection is quite often missed, like I said. Intoing and outtoing, I mean, you guys have so many problems. I don't think intoing and outtoing is your problem. Now, in Britain where I work, half of the patients that come to my pediatric clinic, they come there because I think they have nothing better to do personally. Because they come, they say, oh, doctor, look at this child. When he's walking, his feet's pointing in, his feet's pointing out. I said, look, this child's got 2 legs, he's got 2 hands. What is your problem? When he's walking. When the child stops walking, bring him back. So you see, the variety of pathology that we'll present to you and that I see can be very different. Club feet. I don't know what the incidence in Africa is, but I remember from my medical school days in Nigeria, I think that we think it's about 5 per 1,000 in this environment, but in the UK it's 1 per 1,000. This is a deformity that involves the whole of the foot, the forefoot, the midfoot, and the hindfoot. Club foot can be variable in severity. You can have a very severe club foot, and you can have ones that are not so bad. Okay, and you can have other things, like I said before, that are not actually club foot. Some of which you need to worry about, some of which you don't need to worry about at all. I'll mention them in a minute. Early casting of club foot reduces the need for big operations. Now, if you don't get anything else here today, it is that you all have to sit together and start to think about early treatment of club foot with casting, because it will reduce some of the severe deformities we see here. Briefly, once a child is born and the doctor or whoever took the birth decides that this child's got a club foot, somebody, and it doesn't have to be a doctor, it could be a cast technician, it could be the local physiotherapist. In fact, in my hospital, the physiotherapist does the club foot casting together with the cast technician. I don't do club foot casting. They only send the ones they can't deal with to me. Somebody, even the health technician that you were talking about, Paul, that was supposed to be doing the trauma, they need to be taught how to do club foot casting. Now, for this club foot casting to work, it has to be started to work really well. It has to be started within the first week. So you stretch the foot into the position that it's supposed to go. There's a particular technique for this. And you put a cast on. You bring the child back a week later, stretch it some more, put a cast on. When you change the cast regularly like that, by 6 to 8 weeks, the foot is almost normal. And usually the only thing left to do is to, in clinic, give the child a little bit of local anesthetic, cut the Achilles tendon, and get the rest of the correction. So by 2 to 3 months, most children, not all of them, but I would imagine 80% of children should actually, with club foot, should have a normal foot. But it depends on whether you are willing to invest, and it doesn't need equipment. It just needs time to teach the people who will do it. If you're willing to invest that time, you can actually eradicate deformity secondary to club foot. Because all they need is casts every week for about 8 or 9 weeks. And then it's brown boot and bar for about a year or so that they wear every night. And that's it. And if you do that, you could eliminate something like, I would say, 70 to 80% of the major surgery that I have done in Ghana since I've been coming. So I think that we're doing a lot of work, but really the work we should concentrate on is training people to do early casting of club foot. And again, I emphasize, it's not doctors. You can't spare doctors to do it. Even in the UK, doctors don't do club foot casting. Pathology, I don't think I will dwell on this. The most consistent finding is a deformed talus. Casting, you always have to try first for all sorts of club foot. The most popular technique that we know works is the Ponseti technique. Operative treatment. There's a wide variety of operations you can do for club foot. It's loads, absolutely loads. It varies from simple Achilles tendon release to complex, very complex surgery. And of course, if the child is old and the foot is very stiff, then you need very, very, very severe surgery for that. Surgery is best about the age of 1 if casting fails. Later salvage surgery, if you see 12, 13, 14-year-olds, which I still see in Africa with club foot that has not been corrected, then the kind of surgery you need for those is really, really very serious surgery. It is very difficult, but it can be done. Again, if you don't do it, these children will go through life really quite disabled. That's an example of a club foot. This is a bilateral club, but I think I should show you ones that you're more familiar with. This is a child from last year, 1-year-old that we saw in Ghana. Now this is a typical club foot deformity. The heel is an equinus, and the most important thing about the club foot, how you can distinguish it from everything else, is what I call the clapping foot sign. If you can put your hands together, you can make a clap. Now if you can put the foot together and clap it, that's a club foot. Okay. So if you can't clap the foot, it's not a club foot. Because the most essential deformity in a club foot is supination. All the other pediatric foot pathology don't have supination. So remember clapping foot. If you can clap the foot, it's a club foot. Okay? And this child is nearly about to walk. And again, this is the foot, the deformity. That's the equinus. There's a medial crease there. I won't dwell on the pathology too much. And this is the surgery for that. An extensive posterior medial release, lengthen all the tendons, release the joints, and you can correct that quite nicely. But you see, if somebody casted this child at the beginning, I may not have needed, maybe I would, but I may not have needed to do that surgery. But luckily, this child was seen still early enough for this to be corrected fully. But you see, you need a lot more skill to do this, you see. We should be picking this up earlier. And that is that child's foot again. And that's it in the cast. This foot is normal. This child will be normal from now on, will be fine. There'll be no trouble. This is what happens when you don't do it early. This is a 12-year-old. This child is walking on that. We must have seen some of them. That is absolutely true. They usually hide. They don't like it. And they can't wear any shoes. How can a human being not be able to wear any shoes? No, not at all. So they walk around, they're walking on that part of their foot. So you can imagine how disadvantaged they would be for life. This needs a triple arthrodesis, but it's not a straightforward one. It's a fairly complex triple fusion. And again, this is after surgery. This was done here as well. Now there are some things that look like club foot, but they're not. Okay, that's the one I was talking about. Club foot always starts at birth. You will see some people with the foot you just saw in a 12, 13-year-old that looks really deformed. And everybody says it's club foot. You need to ask, was it always like that, or did it start later? Because in some of the children, and I actually saw one last week, had a similar deformity, but the leg was very thin, and this feeling in the leg was not normal. And when you ask, they say, oh, no, it wasn't born like that. It started about when it was 6 or 7. And the nurse said, oh, shut up, it's not true. It must have been from birth. But it isn't true. You can't have conditions like that didn't start at birth. They're neurological conditions. It's called Charcot-Marie-Tooth. And it's a condition where the nerve is damaged. So the foot gradually deforms. And very often you will have it on both feet, but one side will be worse than the other. So you can't have it, but it didn't start at birth. So when somebody tells you that, don't tell them to shut up. It can happen, okay? Also, you can have feet looking like that in people who've had a stroke. Again, your treatment, a stroke or a head injury, your treatment will be determined by what caused it. And you will have to do surgery to get the foot flat again. You can't walk without a foot that's flat. It has to be flat for you to walk. Flat feet, nobody here bothers about flat feet. The only thing to say about flat feet is, the only flat foot that you should worry about is when the bottom of the foot looks like a boat. You may have seen some of them. You're looking at the foot, and you say, this is a funny looking foot. It's not a club foot, but you know it's not normal. And you look at the sole of the foot, it's like there's a piece of bone under it. Now that's, everybody's nodding. You know what that's called? That's called a congenital vertical talus. It's an opposite deformity to a club foot, completely opposite. The treatment for that is actually surgery, early surgery. So you really should try and refer that to somebody who can do the surgery around the age of 2 years old or so. Again, otherwise that foot will not be normal. That's a flat foot. Metatarsus adductors, these are the ones I was talking about. If the foot is not clapping, it's not a club foot. It's probably metatarsus adductors, okay? And that's what that looks like. There are other disorders that you can find in the foot, in children and adults as well. Infection, trauma, tumor, foreign body. I thought I would just briefly mention infection in the foot. This is usually due to penetrating injuries. A lot of people walk around without footwear, and some have slippers. They're walking around in the bush, something goes through the foot. They won't seek your attention early. They won't come for 4, 5, 6 weeks. By then, there's a swelling. Once they come at that stage and there's a swelling, antibiotics alone is not going to work. You need to open that wound and clean it out completely. Remove the bits of dead bone, dead flesh, otherwise it won't heal. So no point leaving them on the ward for 3 weeks. It won't heal. Okay, can write it down somewhere. It won't heal. You need to clean it out surgically first, and then give them antibiotics and all that, and then it will heal. Okay? Adult foot pathology, I'll run through this quickly. Hallux valgus, you people don't have that problem because you don't wear those stupid shoes they wear to give them that problem. You need to wear stiletto like that, and then you get deformity. But everybody here tends to wear flip-flops. That's good. Don't stop wearing it. At least there's one less problem for you people to deal with. Okay? Hamato heel spur, pain in the back of the heel. It is common here. The treatment is to put a little cushion under the heel in your shoe. That works. If you know somebody who knows how to use an injection, a steroid injection, depomedrone, and some local anesthetic is helpful. Morton's neuroma, the same, but I won't go into any details about that. Adult flat feet. Some adults have flat foot. That's the way God designed them. That's okay. Don't worry about it if it's not painful. If it's painful, there may be a problem. It may be that some of the joints in the foot have collapsed. Go and see somebody who knows about it. Not a medicine man, he won't know. Okay. Diabetic feet. It's a big problem in Africa. And we probably lose more legs than everybody else because we don't look. The diabetic people themselves don't look after themselves well. And we don't look after them as well. They're supposed to check their foot every day and all that. They won't do it. Something pricks them in the foot, they won't tell you on time. So it's a big problem. The reason for it is mainly because they don't have any feeling in their foot. So when they injure themselves, they don't tell you on time. By the time they tell you, they've lost things. Again, everybody's afraid of surgery. Sometimes surgery is the only way, early surgery is the only way you can stop them from losing their leg. If you do the surgery early, remove the damaged bit, sometimes they keep the leg. If you keep waiting, oh, don't touch that, don't remove that toe, the infection spreads, they lose the whole leg. And that's a typical diabetic ulcer. In a child, I will get away with saving that foot. That doesn't end amputation. In a diabetic, particularly in this environment, it's very difficult to treat that. But the treatment for that, if you see a diabetic ulcer like that, don't just cut the leg off. Take the patient to theater, clean the wound until it's bleeding, then put a cast on. We call it a total contact cast. But you must pad it very well, not with this Mickey Mouse layers of cast you put on. You put proper padding on. Don't try and save padding. Put proper padding on, and that ulcer will heal. Trust me, it will heal. This is what I do for a living. Okay? Sports injuries. Ankle ligament sprains. This is common. Everybody gets it, and you get your own fair share. If somebody has an ankle sprain, say the ankle is really, really swollen, and you do an X-ray, and there's no fracture, it doesn't mean that the guy is okay. It's not okay, particularly if you can't walk on it. That's called a severe ankle ligament injury. It's a grade 3 sprain. If you don't treat it, that person is in trouble. Because 1 year later, every time he's walking, I'm sure there will be people here in the audience say, yeah, that happened to me. Every time they are walking, they step on a piece of stone, they nearly fall over. Now, the only way you can prevent that is to treat the patient properly in the first place. So if somebody has a sprained ankle, and there's no fracture on the X-ray, if you are worried enough to do an X-ray because they can't walk on it, and there's no fracture, they still need to be treated in a cast. Did you hear that? They still need to be treated in a cast. Because if you treat them in a cast for 4 to 6 weeks, the ligaments will heal properly. And then they will not keep falling over every time they walk. So the treatment is cast for 6 weeks, and then physio. And they will be fine. If you don't treat them in a cast, they won't be fine. Ankle fracture, we won't talk about that, we don't have time for that. And then severe foot injuries are often difficult to manage and can result in amputation. My own feeling about ankle fractures and severe foot injuries is a lot of fractures around the ankle actually need surgery. The trouble is getting to the person that can do the surgery well and on time is a big problem in Africa. Unfortunately, there's no way around it. The trouble is the technology you need to do the surgery properly. It's not actually a big deal. You need a small fragment set. It costs next to nothing. Every hospital should have one. I don't think that is too much to ask. Thank you.
Any questions for Mr. Adedapo? I have one question, which probably should be a private one, but one of my mates once was working with the Southeast technical whatever on the diabetic foot, trying to develop a sensor to see when there's pressure and things. I'm not sure what the result was, but is there anything going?
The reason why diabetic feet break down is because of the lack of sensation. And B, the area that breaks down is because there's abnormal pressure in that area. That is normal. What you do is when you examine the foot, sometimes you don't even need to do those pressure sensors. There are research fellows in my hospital working on it because I have that system at work that we use for research. Sometimes you can actually feel the area of bony, because in diabetes, sometimes the bones fall apart. Now when you palpate the foot, when you feel the foot, you can feel bumps. And the area that has a bump in it, sometimes after a while they start to break down. If a diabetic has an ulcer, and you feel the inside of the ulcer, of course, put on your gloves, feel the inside, and there's a piece of bone there, that ulcer is never going to heal until you remove that bone. So sometimes you can actually find that there's areas of bony prominence on the sole of the foot. If there is, they will get an ulcer sooner or later. And once they get one, it will never heal until you remove the bone. So sometimes in diabetics, with ulcers, I actually operate to remove bony prominences. Because if you don't, it won't heal. So that is often the case, yes.
The next one is orthopedic anesthesia.
Nerve loss. The nerve blocks are fantastic because you may get a patient who not only has he got severe injuries, but the guy is inebriated, totally drunk, vomited, you don't know really what to do. And if you can do some local anesthetic things to manage a particular problem which is prominent there, I feel quite happier because I'm here. When everybody goes, the surgeon is still responsible, but this guy could obstruct, could vomit and things. So, and the nerve blocks, of course, you need to be taught, but I think there are some simple ones we could pick. And Abid is going to talk to us on the orthopedic nerve blocks. I hope we will all get a few that we can use. This is everything that you need here. And it's located, yesterday I was watching the telly, when which football team was it? The goalkeeper is located at Pathology out there. And the physician went in there. Without anesthesia, just put it back. And I thought it was smart. Because otherwise, you get into the hospital. If you're fortunate, someone will give you a neck block. But otherwise, you get a GA, you just have this reduction. So I think this is a fantastic one that we're going to have. Right.
Hello, everybody. My remit today is to talk about regional anesthesia. And I'm sure you'll all agree that the relief of pain and the alleviation of suffering in all patients is a basic human right. And that's where we anaesthetists come in, really. And regional anesthesia is one of the best methods of relieving this pain and suffering. As we said earlier, that the adequate pain relief is prerequisite for rehabilitation of the patient. Good pain relief provides early mobilization, early discharge, and this is very cost effective. So thus if we invest in expensive equipment, this can be cost effective in the long run. And I shall talk about these equipment later on. Regional anesthesia can also be used as a sole general anesthetic, as we said, and has as a sole anesthetic, and this has many advantages over general anesthetic, which I shall allude to later on. Also, regional anesthesia has become very popular around the world because of the new technology in locating the nerve and thus placing the needles very close by using nerve stimulators and now more recently ultrasound. This has increased the efficiency of the nerve blocks and also reduced the complication rates. Some of the examples I shall begin with is like dislocated hip or fractured neck of femur. We can use easily 3-in-1 femoral nerve blocks. These are easily done, which I'll elaborate later on, and they can provide very good pain relief. And there are many studies which I'll talk about later show this. This complicated knee surgery will require complicated rehabilitation, and thus the pain relief is very essential for this rehabilitation. And in our practice in the UK, we would provide spinal with continuous infusion of epidural. But I've noticed that epidurals are not readily available here, so 3-in-1 block would adequately provide that for a short period of time, plus other methods. But I think we should be training anaesthetists to be doing more epidurals and continuous infusions, which are started yesterday. What is regional anesthesia? Basically, it's the interruption of the pain pathways in the periphery, blocking the sensory nerves, at the same time leaving the motor and the sympathetic nerves alone, thus avoiding the complications of vasodilatation and paralyzed limbs. There are many types of general anesthetics. I shall quickly go through them. Topical, local, intravenous, regional, which is typically Bayes block. Peripheral blocks, we can block any nerve in the body, or we can block plexuses, lumbar, brachial plexuses, or we can have a central blockade using epidurals and spinals. Annoying. In fact, any nerve in the body, I've named them all, can be blocked really, starting with the cranial nerves. If you're doing awake intubation of a patient, we can block the cranial nerves to facilitate that. Or we can block the tibial nerve, which lies behind the median malleolus as it branches into the medial and plantar nerves. We can block that at that point. So every nerve possible can be blocked that. I don't have time to go to all through them, but I'll select some of the blocks which we can easily do, and I shall go through the others later on. As I said earlier, it can be used as a sole general anesthetic. It can provide analgesia postoperatively, and also it can be used as a diagnosis for chronic pain syndromes in patients. I mean, is it really effective? Does it improve the outcome in patients as compared to other techniques? There have been many studies on this. One of the earliest ones in 1936, and that conclusively shows that effective pain relief does improve the outcome. This was not a really randomized trial. It was too early to have any meaningful results really. So many other studies have followed, which have been very inconclusive really. So there's no hard and fast rule whether the outcome is better after regional anesthesia compared to other techniques. But one thing we have to take into account the outcome of the surgical intervention as well as the anesthetic intervention we take. So the two have to go together and not take as a separate. But there is strong belief that when compared to a general anesthetic, mortality is lower. And also superior analgesia with this regional anesthesia results, as I said earlier, a shorter hospital stay. There is reduced incidence of DVTs because of the early mobilization of these patients. It's associated with good cardiac output. There's less effect on the sympathetic cardiac output, venous return, as compared to other techniques. So in patients with severe cardiac impairment, regional anesthesia is far better than general anesthetic or any other technique. Because of mobilization is much, much quicker, these patients have less complications. They can be discharged from the hospital and they're very, very cost effective. In the elderly, they're especially good because there's no deterioration in mental function. I should briefly outline some of the blocks we do really. I'm not going to bore you with the anatomy and the details of it, but I think before we do any blocks, we've got to know the anatomy of the region we're going to carry out the block. The brachial plexus, very briefly, are the nerve roots from the anterior primary rami of C5 to T1. Okay, they join together to form three trunks, upper, lower, middle, which lie in the upper part of the neck between the anterior and middle scalenus muscles, and these then divide to give 6 divisions, which lie behind the clavicle in front of the first rib, and then they go on to form the 3 chords in the neck. So if you block in the brachial plexus in the neck, this will be at the trunk level. This is the interscalene block. At the division level, it's behind the clavicle in front of the first rib. This is the supraclavicular block, and in the axilla, this is the axillary brachial plexus block. Although you want to know brachial plexus in a bit more detail, these are the various divisions and nerves given off of each cord and of the brachial plexus. But I shall quickly run through that. What is important to know that which part each of the 3 cords in the body supply the various parts of the arm, so we know which part to block. For example, if you're doing the interscalene block, that is most useful for the shoulder surgery and upper part surgery. Whereas if you're doing the axillary nerve block, that's more likely to block the ulnar nerve, which is for hand surgery. So it's important to know what surgical procedure is being done before we select the various brachial plexus block. Sorry, this is slow. These are the various blocks, as I mentioned, on the brachial plexus, and depends on the surgical procedure done, and the amount of injected will depend on the particular site. I shall mention those in a minute. For example, if you choose the interscalene block, this is taken from a book by Winnie. There are 2 volumes, volume 1, volume 2, by Winnie on brachial plexus. It's very good bedtime reading, I recommend them. Basically, what it says is that the interscalene block, it can be blocked at this point, as it lies between scalenus medius and scalenus anterior in the neck. These two muscles lie behind the posterior edge of the sternomastoid in the neck. So you feel the posterior edge and go behind that, and this point is located by horizontal line drawn from the cranial cartilage, which is level of C6. So this is from C6 going laterally to the scalenus groove, and will locate the brachial plexus. And the needle, this is not a very good drawing. Right, and the point is marked at that point laterally from the cranial part, and the needle is inserted at an angle of about 60 degrees, pointing towards the opposite elbow, with the arm down by the patient's side. And the local anaesthetic injected is very important. Winnie recommends 40 mils of local anaesthetic, whichever local anaesthetic is preferable, to ease the spread. If less than 40 mils are used, then one is likely to miss the lower part of the brachial plexus, which is the ulnar nerve, the T1. Another commonly used brachial plexus block is the axillary nerve, which is easily done without use of much nerve stimulators and so on. The arm is abducted to 90 degrees with the hand facing upwards, and the axillary artery is located in the uppermost part of the axilla, and the angle is inserted as proximally as possible above or next to the axillary artery, because the plexus lies in the sheath next to the artery, and again 40 mils of local anesthetic are injected. Unlike the interscalene block, the nerve that's commonly missed in this block is the musculocutaneous nerve, so that may have to be blocked separately for tourniquet purposes and so on. Then this shows the anatomy of the axillary block being located as high up as possible so as not to miss the musculocutaneous nerve, and high volume is deposited. The second brachial block, the third one I mentioned, was the supraclavicular, blocking the brachial plexus behind the clavicle in front of the ribs. But we very rarely do this because of the risk of pneumothorax. So very rarely we do this, so I'll just mention it for completion. Other blocks we can do are blocking of the elbow, blocking the ulnar nerve. The median nerve can be blocked at the wrist, next to the tendons of the extensor palmaris longus, flexor carpal longus and flexor carpal radialis tendons. And it's about 1 centimeter deep to the flexor retinaculum, and about 5 mils are injected. This shows the injection at the volar crease, blocking the median nerve next to the extensor retinaculum. Digital blocks are easily done, injecting 3 mils of local anesthetic for finger surgery, limb surgery, and they should be done routinely. Intravenous regional anesthesia is a technique that's been around for a long time. This was invented by Baer going back as 1899, I think. He first described it, where the arm is ensanguinated and local anesthetic injected into the arm. It's not for short procedures, for example, fractures of the wrist or short orthopedic procedures. It's a very rapid onset, but has a problem or complications. If the tourniquet is released too early, one may get local anesthetic toxicity, and that's why bupivacaine or Marcaine is contraindicated in these blocks. and the safest local anesthetic used is Prilocaine, because that can be used in high amounts without causing any problems. So the picture using intravenous, this is the arm being sanguinated, intravenous, the arm being raised to drain the blood out in the tourniquet. There are two double tourniquets in the intravenous anesthesia. Firstly, the upper tourniquet is blown up and the local anesthetic injected. Once that part of the arm is numb, then the lower tourniquet is blown up and the upper released. So that provides good analgesia. One of the commonest regional blocks we do is epidural. It has many advantages. For example, in hip surgery, it allows us to provide adequate or very good pain control. It also allows us to control the blood pressure during the operation, which minimizes blood loss, and also it reduces the incidence of deep venous thrombosis postoperatively. And because of the the best pain relief possible, the patient is mobilized very early and thus can be discharged much more quicker than other methods. It's not really complex, but it needs to be taught on how to do it, and all wards need to be trained on how to look after epidural patients. It's not something that you can do very quickly. Every nursing staff has to be trained on how to look after the level of sensory block, motor block, the complications resulting from it, and what to do if the complications do arise. The epidural space lies just before the subarachnoid space. It starts from the base of the neck going down to the bottom of the sacrum. It's a continuous space, very easily found. I think the next slide demonstrates that. If you're looking at the patient's back, we have the spinous processes. Between the spinous processes, we insert the artery needle or the epidural needle going through various ligaments, supraspinous, interspinous, and then the ligamentum flavum, which is a very thick ligament. At that point, there's a lot of resistance to the epidural needle. So it advances very slowly until there's a loss of resistance. This is loss of resistance technique, but other techniques have been used to locate the epidural space. And the catheter can be threaded so we can have a continuous analgesia post-operatively in these patients. This is the epidural being performed. Spinal anesthetic also is a very, very good technique. Unlike epidural, provides profound analgesia, much faster onset. There are no missed segments, but unfortunately the drop in blood pressure is very rapid and can go very low at that point. So one needs to take precautions on this. But after most hips and knee surgeries, spinal anesthetic is a very, very good technique. In the UK, at the moment, we're doing a rapid recovery program at the moment, where we're utilizing low spinal anesthetic techniques in these two types of patients. And also using OxyContin and other pain relief methods to get the patients out of bed and home within 3 days. In children, caudal is another technique which can be easily done. This is a low epidural done in the sacrum space, and the landmarks I won't go into, but it can be easily located. There are various methods of locating the caudal space by looking at the posterior superior iliac spines, drawing an equilateral triangle. Also looking for the sacrocaudal, which is sacral hiatus, injecting local anesthetic into the sacral hiatus. And large volumes have to be injected, also at the same time. It's a very vascular area. There are many differences between adults and infant spine. The spinal cord is much lower in infants, and also the subarachnoid voice goes down much further. So the complication can be very high in infants if the needle goes too far in. This shouldn't happen, it should all be one page, but it's somewhat changed when I... This is a study looking at fracture nexus femur using 3-in-1 blocks against intravenous morphine. And the results are far superior with using 3-in-1 blocks as compared to morphine. And this was done by the casualty staff, so anybody can be trained to use these blocks. Very easily done. Briefly mention the landmarks of femoral nerve block. The inguinal ligament between the superior, anterior superior iliac spine and pubic tubercle is inguinal ligament. One feels for the femoral artery, just lateral to the femoral artery lies the femoral nerve. And this is blocked about 1 centimeter below the inguinal ligament. It can be blocked on its own for analgesia for the knee, or one can use a 3-in-1 block, which also blocks the obturator nerve and the lateral cutaneous nerve in this 3-in-1 block. Another block that is, sorry, this is not going, I'm going to speed up a bit. This is the iliac fascia block, which is similar to the 3-in-1 block, but without using the nerve stimulator. This is done just medial to the anterior superior iliac spine, and one feels it's a sensation where you go through the fascia iliac and fascia lata. There are 2 clicks. And after that, you deposit 40 mils of local anesthetic in that region without using nerve stimulator. It's a very, very good block for children, and we use it quite often. Other blocks we can do, sciatic nerve blocks. I'm not going to bore you with the details of it, but there are various landmarks, and it's very successful in hip surgery in combination with the femoral nerve block. We're nearly near the finish. Ankle block that can be done on operation of the feet. There are 5 nerves running to the ankle: tibial, sural, deep con perineal, and superficial perineal. All branches of the sciatic nerve, with the exception of the saphenous nerve, which is a branch of the femoral nerve. And they can be blocked at various sites where they run. For example, tibial nerve runs behind the medial malleolus, and the saphenous runs in front of the medial malleolus. They can block those points. Sural nerve runs behind the lateral malleolus, and the common and superficial perineal nerves run in front of the dorsum of the foot, and that can be done in a fan-wise injection in front of the foot. In orthopedic trauma cases, one may see flayed segments, and in the UK we do thoracic epidurals to alleviate the pain and ensure that the lungs are expanded. But here I think simple intercostal nerve blocks can be very, very useful, and catheters can be put in these intercostals. I mean, these can be located, the intercostal nerves are located in the subcostal groove below each rib. So as you pass the bottom of the rib, just go past it and deposit the local anesthetic in the subcostal groove. I think I should leave it there.
And I finished my rotation in Obs and Gynae. I was quite safe with the cesarean section. I get there, the patient was looking at me, the lady was looking at me, and the nurse anesthetist says, "Doctor, get started." How do I get started? The patient is looking at me. I say, "Yeah, local." I just couldn't understand it. So here we have a problem with oxygen. We start with local, we get in there, we give something to get the lady to sleep, then you quickly get the baby out. I was shocked. But then we finished it. Initially, it was a fetal distress I was to deal with. And then I converted it to doctor distress because the doctor was deeply distressed. But fortunately, baby survived, mother survived, doctor survived, and anesthetist was happy. I mean, and I just can't understand why in medical school you don't get introduced to it, man. It's all general anesthetic. And in our theater here, since MotecLife started coming in, we've been doing a few spinals. And I learned you did one epidural yesterday or the day before.
Yeah, we did in many cases. We've been doing one general anesthetic yesterday.
Yeah. So it's possible to teach it.
Yeah.
So why not?
I think that you said the question was not meant for him. But I think the answer lies with him.
Yes.
So I hope that we can organize some kind of training program which could involve the anesthetists, local anesthetists as well. And perhaps we would, yes.
Yeah. Actually, I wanted to stress that point. Unfortunately, in our medical school, see, in our medical school, they don't do it. And most invariably, the doctors, when they grow up, they have a problem. But you realize that in most of the rural hospitals, the anesthetists, the nurse anesthetists use local anesthesia for most of the operations. And this is actually the worry. If the teaching hospitals, they don't make it a priority, then that becomes a problem. And I think it's a challenge for us as senior colleagues. Maybe we should take it up with a college, the Ghana college, so that we can see how we can promote that. Thank you.
Using the blocks for pain control, not for doing a procedure. And I think I would use it for pain control. But now I learned that, yes, I'll use it for a procedure, not for pain control. But now I think we will use it for pain control as well.
Yeah, for the benefit of the listeners who are here, Dr. Raja has got CDs on nerve blocks. But I think that it will be much better if we can organize some kind of training session quite separately sometime to come for the anesthetists in the region or target hospitals to attend. It will definitely be helpful. Certainly, if you have the CD to give you a pretty good idea, but you may be practicing it the difficult way, and your patients may not like you. We don't want that. Thank you.
Infection in the bone, you've got osteomyelitis, and that's about a 1 year's job before you can clear it. So the next paper is going to be extremely important for us all, surgeons, nurses, administrators, because the end result of our work is what everybody is looking out for. And Tomo would look at the antisepsis aspect of things, scrubbing up, and theater care, orthopedic. And I want to think, next to neurosurgery, cardiac surgery, orthopedic is the ones which will also come in seriously for zero tolerance to sepsis. So I think this is a very important one for us. And I believe this is probably the lecture which should underpin how we are moving forward. So Tomo, you have the audience.
Everybody, I'm Tomo from Central One City Hospital. My work is the scrub nurse in orthopedic elective theaters. And orthopedic scrub nurse needs to familiar with and aware with so many things, the product or prosthesis or instrument, everything. So you need to make sure everything before the operation started. Otherwise, it's going to take long time operation. It will cause a long time tourniquet time, anesthetic time. It's not good for patients. And okay. But the very important thing is that in orthopedic, especially, that reduces surgical site infection. So this is of course important for any other surgery, but especially orthopedic cases, we will use the implant. Implant is going to the patient, and then if it's infected, it's going to damage everything. That you need to reoperation. It's really disaster. And one in 10 patients acquire an infection after admission to hospital. This is 1995 in UK, and the more recent surveys tell us about that up to 5,000 patients a year are killed or affected by infections in hospital. So this is who's responsible for that, but for everybody actually. And one of the simplest and most effective measures to reduce the spread of infection is good hygiene. And microorganisms can live within or upon your skin, but this may not be pathogenic. But if this microorganism going to the unusual place, such as surgical area, it will cause a problem. Okay. So now back to basic, and then I will talk about surgical scrubbing technique. Okay. So, okay, but even if you do the surgical scrub technique, you can't kill all the germs or all the microorganisms from your hand unless you go into the autoclave. But it's impossible. But this purpose is to minimize the number of the pathogen. So you need to do proper scrub technique. Okay. So before the scrub, you need to make sure all the hair into the hat, or anyway, to tidy up everything, and put your t-shirt or something into your trousers, and then just be clean, and then cut the nail short, and then remove your polish. Okay, and then if you can remove accessories, it's better to remove. Okay. And so now I can show the DVDs that actually how they are scrubbing. But the sound is not working, but you can see the pictures.
Let me just try this.
Right hand over left dorsal and left hand over right dorsal. Step 3, hand to hand, fingers interlaced. Step 4, backs of fingers to opposing hands with fingers interlocked. Step 5, rotational rubbing of right thumb clasped in left hand and vice versa. Step 6, rotational rubbing back and forwards with clasped fingers of right hand in left hand and vice versa. Take left wrist in right hand, rotation rub up the arm to an inch above the elbow. Spend 1 minute on this entire hand and arm wash procedure. Rinse fingertips, collect nail brush, wet the brush and apply 5 milliliters of heavy scrub. Scrub your nails, not your skin. Repeat for other hand. Discard nail brush and rinse off solution from hands to elbows. This is only done on the first scrub. Apply another 5 millimeters of UV scrub and repeat the 6 steps for hand washing. Spend 1 minute for both hands. Lastly, using the rotational rubbing method to wash the arms as before, this time 2/3 of the forearms to avoid compromising the cleanliness of the hands. Hands must be rinsed thoroughly from fingertips to elbows, allowing excess water to drain from the elbows. At arm's length, to avoid dripping on the sterile drape, lift off one of the paper towels. Tease it open with both hands. Place the corner on your wrist with the towel facing away from you. Without moving the hand towel, move only the hand to be dried. Pat the skin dry. Pick up the corner of the towel nearest to you and rotate it clockwise. This will bring the dry area of the towel onto your hand. Use this to pat dry in a rotational motion. Again, moving the area to be dried and not the towel. Then discard the towel and rotate to the other side. Ensure that you pick up the towel with your dry hand.
DVD for the how to scrub, but the many organizations depends on organization that telling so many different things. But they will pick the all organizations saying just for the first case is enough, unless your hands is soiled. And also about the time, everybody saying in different times. But in our trust, we recommend to 5 minutes scrub for the first case, and 3 minutes scrub for subsequent cases. But this 5 minutes is, of course, just 5 minutes. Keep washing, just up hand, not like this. So, but anyway, you saw the DVD already, so you know how to scrub. But especially the hand part, you can see like these pictures. But also I have like these posters, so I will give you each hospital. So until you remember these things, you can keep it in front of the scrub area, and then you can see while you are scrubbing. Okay? It's okay. Okay. There are 6 steps to hand washing, but anyway, this one is finished. Okay, and try to keep up your hands all the time, like habit. Even during the operation, after scrub, to try to keep up your hands. If you do like this habit, and you don't need to make it dirty any other place. That sometimes if you forget, if you do like this, that this part is already dirty. Try to think about nipple to belly button. Try to put your hands all the time this height. And the drying should be both dry with towels, not rub. Try to minimum the harmful your skin. Okay. And also that sometimes people try to put the moisturizer. But it's okay to put the moisturizer after the operation. But some products say that the moisturizer will cause a problem with the rubber gloves. So I just recommend that maybe end of the day or lunchtime only is enough to put the moisturizer. So without moisturizer, try to minimize to protect your skin. You don't need to use brush every time to the scrub. So the brush or nail pick is enough to use at the beginning of the operation. Okay, and gowning. I just quick show. I'm not showing everything because this afternoon I will have practical session, but I just show something. So every time you need to remember where is the dirty place, where is the clean place, where you can touch. Then even if you panic, that it's okay, that you know where is dirty, where you can touch it. So like gown is folded inside out like this. So it's inside out. So this outside is actually putting you. So yeah. So you can touch this part. You can grab with your hand, and you can open like this, and then put like this, and then you can see this outside part. You don't need to touch. This inside part is touching you. And also, okay, so now going to, I will show you properly in the PM session. Okay, and also, and also gloving technique. There are two ways of gloving technique: the open technique and the closed technique. And in the theater, orthopedic scrub situation, you normally use the closed technique, which is not closed but not showing your hands. So without showing your hands, put gloves. So it might be difficult, but I also have another chart. So I will put in your theaters, and then until you can remember, you can see how to put the gloves. And also in orthopedic, we try to use double gown. I don't know, double gloves. Yeah, in case if you got a hole into your glove. So okay, and the open technique. So open technique is actually that you will touch glove with your hand. So this open technique you will use in the ward or any other situation outside of theater or even the theaters, maybe anesthetist, or when your glove is dirty and when you need to change your glove, you need to use open technique. I just quickly show you a closed technique, but anyway, this one I will show you that the afternoon session. When you open the glove, try to open properly. Otherwise, it will come back. So try to put it like this, and then closed technique is that without showing, and then put the gloves. This thumb to your thumb, put like this, and then hold it. And then turn it like this. And then put it.
So can you show us on this side?
So like this. So actually, I'm not showing my hands, and I'm not touching.
Back.
I'm not touching gloves with my hand. And the other side as well. The side. You can put like this. But all details are in the chart, so you can see in the chart, and then you can practice yourself as well as this afternoon's PM session. And also, open technique. Open technique, you will touch with your hands. So you just need to think is which part you can touch and which part you cannot touch. You cannot touch which is clean part. So it's not dirty, but you need to think like this. So glove is folded like this. So inside part, again, inside part is going to be it's going to touch with your hands. So it's the dirty part. You can touch this part. So take this dirty part and then put your hands in. And then do like this, and then the second part, so this part is already clean, outside. So just two differences.
Let's do an operate.
Okay, thank you very much.
Give another number.
Your hand cream every time you do surgery. Just use it once in a day.
Yes, the hand cream. Let's hope nobody uses it in between cases. And then what she said, the 3 minutes, it's using heavy scrub or povidone, any of these proprietary things for scrubbing up. What she didn't say anything about soap, whether ghee soap or whatever kind of soap. It is these things that must be used and for 3 minutes. So please, if you are using any other thing, then you are not supposed to be scrubbing. But Tomo, I have an issue with you. You mentioned we should keep our hands between the nipples and the belly button. If you look at Paul's belly, if he doesn't control it, the time will come, you are lowering the lower level too low. So I'm not sure what we'll do about it, what we'll use as the limit. Now, I'm wondering about the close gloving. Could we all adopt it as a standard? I mean, yes, the open gloving works. If your gown has the open sleeve out there without the flannel sleeve, then you'd want to use the open gloving. But even that, when you try hard, you can. But the close gloving, in some theaters, it's mandatory. If you don't use that, the nurse will glove you so that you don't touch the outside of the glove. And I would suggest we try and use that. And thanks for the tip. Sometimes after we've done a number of cases, skin itches. I know it's been upgraded. Occasionally, I think when I'm in a hurry, instead of mopping the hands dry, I rub. And I think it's not too good. Wash it thoroughly, rinse it thoroughly with water, and then mop it dry. That's what is coming through. Because if you don't do that, I get a dermatitis, and that also causes problems. Yeah, so Tomo, thank you very much. Any questions?
I'm Lucy Fuswapia, a peri-operative nurse from St. Joseph Hospital. We are saying that we want to prevent infection during surgical procedures. Fine. You have talked about washing or scrubbing our hands, the technique. What about cleaning the patients?
The lecture did not really address that, but we could discuss it. I think it's important.
Now, the question is coming back to you. What do you mean by cleaning the patient?
Okay, thank you. I mean the skin prep. Skin prep.
Skin prep is also important thing, and of course, if it's soiled already, of course you need to clean first and then start preparation. But when the preparation, they're recommended to if you do the operation, this part, start with operation part, and then go to outside, the dirty part at the end. So always start from the operation part, and also. We shouldn't do, but normally I see is that you shouldn't use the same swab after swab and then dip again and then do it again. This is not practical actually. So every time when you use the sponges or swabs, it's better to change it. And then all the time use a clean swab and then start with the most clean part.
You get it? Okay. So start from the surgical side and go away and throw away the first swab you've used and go for a fresh one. You don't go back dipping into the same pot. And also, you don't take a dirty part that you've cleaned the swab back into the surgical side. Any more questions before? Yeah.
I believe we are going to practice what we have heard all this morning. If we did that, then the Motec visits and you're coming up would happen good But there's something interesting happening. There's going to be a lunch in the hotel.
No, just the name of the hospital.
That's fine. So the next thing really is to drill for your internal rotation, and use the H block, which is this.
Yeah, this card.
Just cover 50% of the previous dimensions.
Now, we've finished the whole process and I'm ready to go. This is an excellent cameraman, and if you can see with me over here, I'm just packing up. You can see how everything is going smoothly. This is sawdust, so you can see sawdust.
So that it will become a national affair. In fact, we all have a lot today to pick, not only for orthopedics, but in the whole sphere of trauma management. And it cuts across the nurses, the physiotherapists, radiologists, and trauma covers every part of medicine. Orthopedics covers every part of medicine. And I'm proud that our medical superintendent, herself being a gynecologist, is among us here and is taking a very good interest, a lot of interest in the whole process. We had one orthopedic gynecologist also from who has left us, so we had to go on a call. And in a way, I'm not going to say give the vote of thanks. I only want to say that we thank all of you for having this thing to sit down, where I think the number hasn't changed so much. Some few people have left, but the majority of us are here. And thank you for the honor done us, and done me especially to chair this occasion. Thank you very much.
So, the day has come to an end. On behalf of VRA and on behalf of Motec, we say a very big thank you to all of you, and we wish you a safe journey to wherever you are going and a good evening. Thank you all. Thank you. The closing prayer. Is there anybody who has been moved by the Spirit here today?
Lord. Can we be on our feet and stand? Father Almighty, we thank you, we bless you in the name of Jesus. We have lit your holy name at this hour because we've called upon you and you've done exceedingly above what we even asked. Father, all that you have imparted into us this day shall not just be for our stay here, but to be for the good people of Akosombo and beyond. We shall use it to save your own created lives. Father, you have brought us here safely. You stay with us. We still ask for your mercies to travel with us both near and far, that at the end of the day, when we arrive at our various destinations, we shall never forget to give you thanks and praise as you deserve. In the name of Jesus, I pray with thanksgiving. Amen.
Amen.
Hello. Please, Mr. Richard Yebua Dambwa, if you are here,